Good evening, good morning, good afternoon, everyone. Thank you so much for joining us today. So this is the part 2 of the two-part live webinar series with Professor Jod S Mehta. Welcome everyone for today's session. So before we start, I wanted to orientate you on the webinar platform that we have today. On your right, at the top right, you will see a few tabs, mainly the Q&A, polls, and handouts. So feel free to type in your questions throughout today's session, and we will publish all of the questions at the end of the talk. You can also download the handouts for your easy reference, and the polls will be actually open now to actually invite you to share some of your experience with us today. Okay, so today is actually session 2 of this two-part cornea surgery series, and today will be on DALK surgery. This will consist of a 45 minutes talk as well as a 15 minutes Q&A session. All right, so a bit about our speaker today. Professor Jod Mehta is the Distinguished Professor at Duke-NUS Singapore National Eye Centre. He is the head of the Corneal Service Singapore National Eye Centre, head of the Tissue Engineering and Cell Therapy Group, named Professor of Clinical Innovation at Singapore National Eye Centre, Director of Education, Sing Health Transplant, and Deputy Executive Director at Singapore Eye Research Institute. Prof. Jod has published over 390 peer-reviewed papers and 20 book chapters. His work is focused on corneal transplantation, femtosecond laser technology, corneal imaging, corneal infections, corneal refractive surgery, keratoprosthesis prosthesis surgery, and corneal genetics. All right, so without further ado, we will then pass the stage over to Professor Jod for his talk today. Okay, so over to you, Professor Jod.
Great, thank you, Phoebe. So I'm just going to go to my slides.
Yep, so you're sharing your screen now.
You my screen. Okay,
this.
great. Okay, so you can see my screen?
Yep, so over to you now.
Great, okay. So good evening, everyone, and good morning. Thank you for attending this second session. So we're going to be focusing on DALK today after last week's webinar, which was basically on EK surgery as well. This is my financial disclosures. So we'll try to look at basically different types of DALK surgery, comparing basically to PK, a little bit on DALK surgical technique as well. And then I would really focus on obviously the role of intraoperative OCT. For some of you who were on the webinar last week, you'll know something about the Leica intraoperative OCT microscope. From those that don't, I'll show some of the slides from that last week, just showing about technical aspects, and then show you some individual cases that we've done with our early experience using this device on DALK surgery. So it's 115 years since the first penetrating keratoplasty was performed in Europe by this guy, Edward Zerm, or this gentleman over here who had bilateral corneal blindness from a chemical injury. And most of you will be familiar with this full thickness corneal transplantation procedure. Now, over the last probably 2 decades, there's been a significant shift in the way we perform corneal transplantation. Last week, we talked about EK, where essentially you're just changing the diseased endothelium and maintaining the anterior layers. And today we're focusing on basically anterior lamellar keratoplasty, where you're basically changing the anterior layer of the cornea and you're maintaining the endothelium of the patient. The reason why this is important is that, of course, we know the most common reason why grafts reject is normally from endothelial rejection. So if you can maintain the patient's own endothelium, you should get basically graft survival. The whole lamellar sort of emphasis has changed the way we practice corneal transplantation really over the last 15 years. This graph on the left-hand side shows basically the rates of corneal transplantation. PK in blue, you can see it dropping from 2005 to 2018. EK, of course, is the most dominant procedure, but I want to focus on the green line over here, which is anterior lamellar keratoplasty. And you'll see between 2005 and 2018, the numbers from the US actually haven't increased hardly at all. And this is pretty much a flat line over these 13 years. In Singapore, it's slightly different. You'll see, of course, same with red line that I showed last week with the EK rates rising, but you'll see the anterior lamellar rates are also quite high as well. And we do almost about 28 to 30% of our cases as anterior lamellas. My rates are normally about 30%. And you can see PK is well and pushed into the third pace kind of surgery that we'll basically perform. And there are reasons why we prefer to basically doing this, which I'll go over the next couple of slides. But anterior lamellar actually is the second most common surgical corneal transplantation procedure that we basically perform. The reason why we perform it, of course, is because you get much better outcomes. In this Kaplan-Meier survival curve, basically showing penetrating keratoplasty over here in blue, compared to EK in red, compared to anterior lamellar keratoplasty in green over here. And you can see up over here, after 10 years, you're almost getting 90% survival of your anterior lamellar cases, which is an outstanding, basically, result to get compared to what's achievable with penetrating keratoplasty. So if you can get your basically, or manage to do a DALK procedure on anterior lamellar procedure, and this will equate to better long-term graft survival for your patients. So recently, lamellar keratoplasty, even though it was the first procedure that was performed prior to PK, it was basically given up upon because the results were basically poor with respect to visual acuity. More recently, however, due to improved surgical techniques and instruments, which we'll talk a little bit about, and this has been there's been a sort of whole reemergence of this basically technique, and this has been supported in the literature. This is from the American Academy of Ophthalmology back in 2011, and this is one of the OTAs that the Academy does, and they basically were comparing DALK to penetrating keratoplasty. So there are 11 studies looking at as a comparison, and if you look at best corrected visual acuity, it showed the results were equivalent between DALK and basically penetrating keratoplasty. There was no difference with respect to refractive error, so of course, your suturing and stuff has to be important for DALK, as it basically is for penetrating keratoplasty. But of course, there was better long-term graft survival, better endothelial cell loss, as you'd expect, with superior to DALK compared to penetrating keratoplasty. The eye was basically tectonically stronger. There was less intraocular surgical complications, of course, as you'd expect, because it's not an open sky procedure, and this is really related to systolic macular edema or suprachoroidal hemorrhage or endophthalmitis. And of course, there was a lower risk of endothelial rejection because, of course, you're not basically changing the endothelium. But one of the other key advantages of the DALK procedure is this last point over here, where you can basically expand your donor pool. And what I mean by this is that instead of using tissue that has good EK, when you become an experienced basically DALK surgeon, you can take tissue that actually has poor endothelial cell count, so less than 1,500 even, and you can, and as long as it has a clear stroma, you can use this basically for DALK, or in some cases you will know that you can use 2 tissues for 1 patient as long as you have adequate tracking, and you can use the endothelium for basically for DMEK, and then the stroma basically for DALK case. And in cases like now where we have the situation with COVID, of course, better utilization of your tissue becomes all and more important. So the goal of the procedure is really to get as deep as possible. And there's 2 main types of basically deep anterior lamellar. One is what we call a pre-decimase dissection, or basically down to above Dua's layer. And this basically involves any dissection from basically mid to basically posterior stroma. What I'm saying by mid to posterior, I'm talking about 100 microns away from decimase membrane. And there's different techniques to try to do this. You typically can do it with manual dissection. People have tried using femtosecond lasers, or you can use basically Melay's technique, which involves a use of different dissectors. And there's the decimase bearing technique, which is basically total stromal replacement, where you're removing all of the stroma itself. And in order to achieve that, there's again different techniques to basically force the separation of decimase membrane away from the stroma. This can be done with an air bubble, initially described by Mohammed Anwar, or it can be done with hydrodissection with fluid, or it can be done basically with viscoelastic or viscodissection. I'll show you some techniques. Or it can be done painstakingly with a manual dissection technique, removing all the stroma itself. And this is something that we basically see as almost the holy grail when we're doing basically DALK surgery. So is there evidence in the literature that less stroma is better? Well, the answer is there is. And this is one of the first papers basically showing this back in 2007. This was done when I was a resident in London. And you can see from this paper over here, when they looked at 32 cases of DALK, basically with keratoconus, if you had a residual stromal bed of less than 20 microns, you got basically better visual acuity. If the residual stromal bed was greater than 80 microns, it seemed to me worse. Now you could think, well, hang on, why does this OCT look a little bit strange? And that's because this OCT was done with the Stratus OCT, which is a very old OCT that was actually used for retina. And what we did was that we changed the focusing to give us a hyperopic adjustment. And that's how we basically attain this image. And that's why the range of the micron thickness is actually quite large in this paper. Subsequently, with newer OCT devices, it has been shown from Panorama's group in Italy. Again, they basically felt that around about 20 microns seem to give you better visual acuity compared to those with greater above 20 microns. And this has been shown also clinically in other series when you compare different techniques. So our paper back in 2009, where we compared the big bubble techniques down to decimate membrane, compared to a DALK technique where it was a manual dissection versus penetrating keratoplasty, you can see that even though you had good improvements with visual acuity at 1 year, you did have superior visual acuity in the A technique, which is down to decimate membrane, or what we call the AMWA technique, compared to basically the manual. So this shows that even amongst DALK, there's different techniques that are going to give you an improvement in visual acuity. This has also been shown in other series from Iran, comparing decimate bearing DALK versus pre-decimate. Again, was showing similar kind of results. But at 3 months after suture removal, the best corrected visual acuity in this series was similar. With the series from Italy, again, comparing big bubble technique compared to basically pre-decimate dissection technique, the best corrected visual acuity was faster with improvement with the decimate bearing technique up to basically 24 months. So again, showing similar results to basically what we showed in our basically series as well. And this is the thing that you have to remember. Basically, the deeper you go, of course, you're going to get better visual acuity. But unfortunately, the deeper you go, you're also going to increase your risk of basically perforation, either from the dissection or the suturing. So there's all this balance when you're seeing patients that you want to go deep to basically get better visual acuity results. However, if you go too deep, of course, your risk of complications has to be higher. And we know that the long-term outcome for DALK is better for patients compared to penetrating keratoplasty. So this always has to be thought of when you think about the patient a bit more holistically about when you're doing basically the surgery. So we published one of the first papers looking at intraoperative OCT to help overcome the learning curve of DALK, and this was basically back in 2014. And this was using a standard device, using an RTV OCT device, which is a portable device. And what we did was we hitched this up to a basically microscope stand. You can see over here when I'm doing the surgery, the patient's eyes over here, and you can see this peering over. Now, the operating microscope actually has been basically moved away. What we're able to show in that series is that we've got good information about the stromal scarring intraoperatively while we're in OT. Of course, this could be done pre-op basically as well. When you're doing the dissection, it gave you an idea, a better idea basically on your depth when you're doing your sharp dissection with the crescent plates. You knew exactly the plane that you're in and how much you had left to basically decimate membrane. If you were attempting basically a big bubble, it was possible to image over the needle or the cannula itself, but of course you can't image through it because you get a shadowing like you can see on the right-hand side over here where the OCT cannot penetrate through the metallic needle. And then basically once you try to get a bubble or you didn't get a bubble in this situation, you can see this partial separation of decimate membrane over here. So again, it can guide you with the surgery. And this just basically showed you that how much information that you were getting when you were doing the surgery itself. And certainly I felt when I was started using this, you felt that you were able to go slightly deeper during the section because you had this feedback. Previously we were using an intraoperative pachymetry device, which sometimes didn't work so well when you were down to about 80 microns. But of course with OCT, this can overcome this. And this just shows you an example of a case of one of the patients from our series. So we go on basically use keratoconic. So we tried to get a big bubble. So you can see the bubble over there as well. Okay, so the bubble basically been formed. And if we did intraoperative OCT, in fact, you can see this line over here. And this is the separation of decimate membrane away from basically the stroma. And this is typically a type 1 bubble. And you can see this nice separation over here before we basically did the brace trash. And we carry on basically doing the stromectomy. So it just shows you that if you're not sure of the clinical sign, that you can get the bubble and you can OCT through the stromal emphysema that you get basically when you basically inject the air. Here's another example over here where again we're trying to get a big bubble, but this time you get basically a whiteout. So you're not really sure what's going on. We did basically an OCT at this time, and I'll show you basically what we basically found. So I take off one more layer of the stroma dissection, and then we're going to basically do an OCT. And this is basically what you see. And what you can see if you look closely is that with the air injection, this is a patient with corneal dystrophy. You can see that there is actually some separation over here with the air, but there's no basically complete decimate membrane separation or basically a complete bubble. It's certainly not a type 1 or a type 2 bubble itself that's basically split in this area, but you can see there's some small separation. So typically in these situations, I'll switch to doing a visco dissection technique. And what I do is that I will switch basically the cannula. So it's the same cannula. And instead of putting air through there, I will basically use visco to help me with the dissection. So I put the basically visco and then I will inject with the visco. So this is what we call a visco bubble. And when you see this transparent, basically a thing occurring on the surface, you've got a nice separation over there. Now this will not extend all the way, so you inject as much as you can up to basically about maybe 6 or 7 millimeters, and then you'll continue to slash away the viscoelastic, and then carry on with a stromectomy. And then basically once you can extend the margins out to the area of your graft, you can then carry on basically removing all the stroma all the way around. Okay, and this is your classical, what we call visco dissection technique. It's quite a nice technique to do. The downside of visco dissection technique is that if you have viscoelastic, or you inject viscoelastic into the stroma, you do have to make sure you remove it all from the stromal bed, because of course it's not going to disappear like we're there. Sometimes this can basically happen. So this is another case where we're doing a visco dissection technique, and here when you inject the air, again you get another whiteout. Okay, so you get another whiteout similar to what I showed you on the previous scan. This time we go put the viscoelastic cannula in. Okay, so again, same DALK cannula. I'm injecting viscoelastic, and look what happens over here. And instead of getting that clear bubble basically on the surface, you get this like whitish cottage cheese appearance basically on the surface. So of course this is not a visco bubble. Okay, and I'll show you basically what this is. If you do an OCT scan, you'll see actually here what's happening is the viscoelastic is actually going intrastromally now, and it's expanded the stroma all the way out, okay, to almost about 1,300 microns. And you can see the separation of the stromal layers by the viscoelastic. Now actually you can use this to your advantage, because basically once you sort of video on this side, once you actually pierce the stromal bubble, it will actually basically allow you to dissect away. This video doesn't seem to be working. It allows you to actually dissect away all the stroma above the area, and you can see this at the end of the surgery. We just get down to about 30 or 46 microns of tissue with a bit of stroma basically on the residual surface itself. And this is basically allows you to remove the stroma. And the stroma is separated by that viscoelastic, so it allows you basically to do the dissection. And of course, I mentioned last week as well that the two sort of landmark studies are Pioneer and the Discovery study using intraoperative OCT. And most of the cases in the study were basically actually done with DSAEK or with DMEK, but there were some cases from DALK, and they showed again that you basically be able to, during lamellar keratoplasty surgeries, in about 1 in 2 cases, it basically affected the decision making that you were getting by the feedback from the intraoperative OCT. So these are some of the issues with some of the OCT scans that I've basically been used over the past. Typically this one in the middle over here, you cannot use the microscopes. The microscope has to be moved well away when the intraoperative OCT is basically in position, and it's difficult to maneuver. You have to use the foot pedal over here basically to get the scan. The scan was good quality, but it's very difficult to maneuver, and somebody had to move the scan into position itself. And even with the Pioneer study, you cannot use the microscope and the intraoperative OCT basically at the same time. So this is showing you the Leica Provia 8, which I introduced last week to use for EK basically surgery. And now we're going to basically use it for DALK surgery. These are some of the key features I think that are basically important. Was basically the lateral resolution is 15 to 31. And that's important when you're thinking about the resolution of the depth, although we're trying to do anterior lamellar in a region of about maybe 40 to 50 microns away from Descemet's membrane. It takes a lot of basically scans at a very, very fast refresh rate. And one of the best features, I think, of the microscope is this point over here, is that you can do crosshairs and circular scans, which again, I think is a massive advantage or basically disadvantage of when you're doing basically complex DALK surgery, because you can get a really good idea of all the way around when you're doing your dissection as well, about how even your dissection plane as well is. And we'll show you some examples on how to do that. So I'll show you this first case. Is a 70-year-old lady. And you can see from the picture over here, she has this old scar, I think from interstitial keratitis. And you can see on the OCT picture over here, actually the scar is actually quite deep. And you'd think, well, it's down to basically Descemet's membrane. So it's scarring all the way around over here. So maybe you should be better off basically having a penetrating keratoplasty compared to basically a DALK. And I mean, a lot of people would basically think that because of basically the depth of the scarring itself. And that's what the initial basically discussion was. So typically when we do basically DALK, we take off the first layer of basically tissue. So we normally do remove down to, so we're about 150 microns away from basically Descemet's membrane before we will do an injection either with viscoelastic or basically air. So this is the anterior keratectomy being performed in basically figure 8. So this is basically pre-op over here, you can see in C, and this is actually what we saw on the intraoperative OCT over here on the right-hand side. Now this haziness over here is basically from the scar, so this is equivalent to this scar over here. But what you can see is that underneath here, actually you can actually see no scar, you can actually see stromal tissue. So what this tells me is that actually there is a plane here, there is a plane here close to Descemet's membrane, that if it's possible to get to that plane, you can be free of the scar and you basically remove the whole scar en face. And the reason why you can't see this on the preoperative scan is sometimes you will get acoustic blockage basically from the scarring itself, giving you a misinterpretation that the scar is deeper than basically what is happening in reality itself. So this basically then gives you an idea that actually you can get deeper than here itself if you can basically find this plane. So we did a visco-dissection technique over here. So I injected viscoelastic inside the eye. Now I'm just basically doing the brave slash, so you can see the viscoelastic coming out. Oops, let me just go back. So I'm doing a brave slash, so you can see the viscoelastic basically coming out, and on the OCT, you'll see the separation over here of the stroma and the viscoelastic basically above the surface. Okay, then I'm extending the stromectomy on the surface, so using this DALK dissector to help me find that plane, and the OCT can show you how much residual stroma basically you're leaving behind. Okay, now this typically IK scars are very adhesive, so when you do the dissection, you have to be very careful when you're pulling on the stroma itself. And as I showed you previously, is that once you get the stroma into the viscoelastic into the stroma, it does allow these basically planes to open up, and you can often go deeper than you can basically imagine. So now you can see the stroma basically on one side, and I carry on with the dissection. Normally I will start on the periphery and basically work my way centrally because the cornea is normally thicker. And then on the left-hand side, I'm gently trying to lift up the thickness of the stroma. On the right-hand side, I'm peeling it away from this pre-Descemet's basically plane. So this is a pre-Descemet's dissection, so it's pretty deep, but it's pre-Descemet's. And you can see on the OCT that I'm doing it quite carefully with the force. So I'm actually trying to not disturb the Descemet's membrane. People always ask, how much do you pull on the surface? It's very difficult to quantify the feeling, but you can see on the OCT that it actually is not being basically perturbed as I'm basically doing the dissection. So this is some of the key steps from the procedure itself. So this is basically the first step after we've done dissection. This is after we've done the visco-dissection technique. You can see the separation over the pre-Descemet's layer over here, the viscoelastic in the stroma. And this is basically following dissection itself. So I'm holding on to the surface over here, and I'm using this blunt lamellar dissector to help me basically gently pulling with on the stroma with some Bond's forceps, and I'm literally peeling the fibers away from this pre-Descemet's basically plane with this instrumentation. But the key is that you're not going to basically pull so much with your left hand that's holding the forceps, and you can see that there's minimal distortion on the OCT imaging. So of course, once you've done the dissection, you're then going to basically put the cornea on. So that again, you're going to remove the Descemet's membrane from the cornea, and then the DALK, and then the OCT can help you basically with your suturing as well. Now, obviously, the alignment is going to be perfect because it's the same size graft. But of course, one of the risks of when you're doing the suturing is that you can get perforation. Perforation can happen in about 20 to 30% of cases. Obviously, this is a micro perforation, so you wouldn't have to convert the procedure, but you may get a double anterior chamber basically at day one. And one of the advantages of basically the OCT you'll see at the edges at the moment, it will help you with the alignment, help you make sure that your needle is absolutely flat when you're basically doing the dissection, and you can see the apposition of the graft during basically the suturing around the edges as well. Okay, and it'll help you also give you an idea of how much tension to do, so you don't get any epithelial wound healing basically problems on the surface. So this is that same patient. This is pre-op on the left-hand side, and basically this is now post-op on the right-hand side. She's got a bit of a cataract, so she's just waiting basically to go undergo cataract surgery, and you can see the dissection plane is pretty deep basically on the post-operative OCT in basically figure D. So that's a standard basically DALK case where I think the OCT can help you guide it. A little bit more complicated than a keratoconic, for example, which is normally a clear stroma, but it shows you the value of having that extra information when you're doing basically your DALK dissection. So what about a more complicated case? So let's show you this case over here. So this lady we saw very recently, a few weeks back, she was sent to us from one of the outreach hospitals. Basically came up there with a red eye. She was referred to SNEC. And you can see this full corneal total abscess over here on this side. I think she's about 83-year-old old Chinese lady, and basically she's complaining, not really much of pain actually, ironically, but she basically told me she was getting discharged basically from this side. So this was scraped, and it turned out to be basically a Pseudomonas infection. There was no basically spread to the vitreous cavity, but you can see she has this full corneal abscess over here. It was sensitive to KEF, I think, and she was on Cravit. Initially, I think we were scraped her also for fungal just to basically be sure, but the fungal results came back as negative. But she came back as Pseudomonas, and she was positive to pan-sensitive to some of the antibiotics that we gave her. So we gave an intensive course of antibiotics, and you can see the picture over here on the right-hand side. And she responded quite well. So responded well to the antibiotics. But what you can see is around the edge, the cornea has melted almost basically down to about 80%. But if you look very closely on this side over here, you can see that actually she's got a small microperforation, and the AC is actually shallow now. The AC is actually shallow now itself from this basically microperforation. So the plan was that we we're going to have to do some surgery for her to help her basically cure this problem. So I'll just stop this in a minute. So this is basically in the OCT. This is basically the perforation where I've got the spear basically on the surface on this side over here. And you can see on the OCT, just on the crosshair, that the AC is completely flat. And it's basically, in fact, that where she had the perforation in the central area on this side, this is where basically all the tissue is basically prolapsed basically to this area. Now, I think that a lot of people in this situation will probably do a penetrating keratoplasty, okay, because of the fact that she's got a perforation in this area. But it is possible basically to do a DALK, and especially if you can get extra feedback from the information that you can get basically from your OCT. So I'll show you basically what we did in the situation. Now, she's still on intensive antibiotics, and you can see that obviously she has had pretty good response, even though the cornea is melted, but she has her hypopyon still left in the anterior chamber, but it's a lot better than the preoperative picture that I showed you itself. Oops. Okay, so this is the surgery. Let me show this again. Okay, so this is the surgery. So first of all, we're using the 360-degree scan to go all the way around, and you can see the AC is absolutely flat all the way. Sorry, the AC is absolutely flat all the way around. Okay, so I'm trying to basically work out if there's any AC at all, but you can see from here it's absolutely flat all the way around. Okay, so we mark out the area that we're going to basically do the graft. So this is just a cell antified. Then what I'm doing is I'm going to the area that's necrotic basically tissue but slightly thickened. I'm using that lamella dissector that I showed you on the previous video to help me basically ascertain the plane. On the OCT, what you can see is you can see the level of the lamella dissector, which is that silver thing moving across the surface over here, okay, to see where I am in the stroma, but I'm above the area of basically where the iris is. Obviously, this is the anterior chamber maintainer over here, and I'm dissecting away all the necrotic tissue. It's always best in these kind of situations to start away from the area of perforation, because of course you don't want this basically perforation, which is a hole, to turn into basically a rip. If you get a rip in the Descemet's membrane at this time, it's a complete nightmare. It's a lot more difficult to salvage. You can see on the OCT, when we reduce the circle, you increase the resolution of what you're able to basically see. So when you get a circle, reduce the circular size, you can nicely see the stromal dissection plane that I'm trying to basically find with the dissector to remove basically the stroma, the necrotic stroma away, and leave a basically a nice clean bed that's as thin as possible, because of course we want this graft to basically last longer. So we try to leave as thin a bed as basically possible, but also remove as much of the necrotic tissue all the way around the dissection. Okay, so on the OCT again, you can see we made the circle smaller again to look at the area of basically the dissection, and we're working our way around now to basically remove as much of the stromal necrotic tissue as possible. So once we've ascertained the plane in the periphery, we'll then work our way to the center, which is obviously where the area of where the perforation is. Okay, you can see when you're scanning all the way around now, so the periphery looks pretty reasonable. Okay, and I'm coming to around the central area to remove all the necrotic tissue in that area. Now again, we reduce the circle size. You can see the hypopyon at the back of the endothelium and an endothelial plaque on that side on the OCT scan using the 360-degree image around the area. So you know it's basically that's an endothelial basically plaque. Now, we enter the anterior chamber, and we're injecting some viscoelastic now to reform the anterior chamber and to get a separation of the iris away from the endothelium. I'm gently using the anterior lamellar dissector to push the iris away backwards. Okay, so I'm pushing the iris away down. You can see on the OCT scan where I'm going across with the lamellar dissector itself. So I'm trying to keep it as flat as possible, so I'm not touching the lens, but I'm also basically trying to make sure that I'm in a plane that's away from the back end of the cornea itself. Once we basically inject the viscoelastic, you can see the AC is now basically formed. This is the DALK, basically tissue being prepared. So we're removing the Descemet's membrane. Now we simply basically place it into position, and then it is sutured in the usual manner. You can see the plaque of the hypopyon on the back, or basically the endothelium, and you can see the edges are quite well aligned. There's a slight separation over there, which will go with further suturing. So we carry on suturing, then we basically remove the viscoelastic. I'm trying to wash out the anterior endothelial plaque. Then basically with an air bubble inside the anterior chamber now, we'll carry on basically doing the rest of the suturing to get some apposition between the Descemet's membrane and the stroma against basically the new graft. Okay, so let's look at some of these points in a little bit more detail. So this is basically the first picture itself that you see at the beginning. This is the area of perforation where the ampua is on this side over here. Okay, this is the basically scan showing the crosshair. Obviously, this completely flat anterior chamber, but it shows you there is some thickness of the stroma. Obviously, it's thinner where the area of the perforation is compared to basically the peripheral area. So that's why I started in the periphery in this kind of area over here itself. The vertical scan on this side, which is this one over here, shows you the depth of my dissector. So this is my dissector basically over here, the silver line. So it shows you I'm basically splitting the stroma over here, and this is basically the anterior chamber on this side. So it shows you the level I'm at, basically removing as much of the stromal tissue as possible. So here it shows you some more pictures using the dissection and the OCT, basically helping you show you where I'm lifting up the stromal tissue. And you can see here, I'm basically cutting or basically dissecting away the stroma almost down into basically 20% over here and 80% basically above my dissecting plane. So the residual stromal bed over here is going to be pretty thin when we basically finish the dissection. So you can see it clearly delineates the area, and it's important to ascertain the depth in the periphery before you work your way across to the central area. Likewise, on this scan over here, you can see on both these images over here, when we made the circle smaller, the resolution is actually better. You can see the delineation of basically the dissection plane in the stroma itself compared to basically the anterior chamber or the iris basically beneath that as well. Okay, so this is basically after we basically finished the dissection all the way around and I removed the tissue from the surface. You can see now the hypopyon clearly up against the back of the Descemet's membrane. There's a plaque basically there itself. These basically spaces are obviously in the anterior chamber, but you can nicely see the delineation of basically the Descemet's membrane away from the hypopyon. And of course, this is basically probably the anterior lens capsule basically over here on this side. And the 360-degree scan allows you to basically see this all the way around. So you can get a good view all around where you basically see these kind of spaces. So this is after we injected the viscoelastic. So typically we use Helon in this situation. So as I inject the viscoelastic, you can see there's a separation of basically the tissue. So you still got a hypopyon plaque at the back of the surface, but the iris is basically being peeled away. And then you can see over here when I'm using the dissector. So this whitish line over here is the dissector, basically dissecting across the surface of the iris, across the lens itself. And these are the residual areas of hypopyon above the dissector itself. Okay, so you can see the hypopyon over here, and this is my dissector across basically the iris plane, allowing me to separate the iris and the hypopyon away from basically the back of the endothelium. This is when the anterior chamber. Oops, let me go back. This is when the anterior chamber is completely reformed now. So the lens has basically gone back, and now you can see the bit of the hypopyon. And this is the stroma dissection that we've done all the way around, and you can see this in this image over here. And this one over here has the initial bit of the DALK tissue lying basically on the surface. And of course, these two pictures, these two things have to realign between the graft and the recipient, basically host. On this scan over here, on the left-hand side, you will see better alignment of the tissue as we're basically doing our suturing, because this tissue was quite old. So it's quite interesting. Initially, they were going to give me a tissue with a cell count of 2,200, but unfortunately, the tissue didn't pass or we didn't get a result back for dengue for the graft itself, or chikungunya. So basically what happened is that they then told me that that tissue had to be, that we couldn't use that tissue. So they gave me another tissue that only had a cell count of 1,000. Okay, so this is one of the advantages, is that if you do DALK in this manner, it allows you to have open access to basically tissue. And of course, with a perforated eye, you want to basically do the surgery as soon as basically possible. So once we carried on with the suturing, you get a good apposition. You can see of the dissected plane of the recipient tissue with the donor. We're now removing the OVD from the anterior chamber, and I'm removing a bit of that plaque as well from the back of the endothelium. We give an injection of intracameral antibiotics inside the anterior chamber as well, while we're basically doing the visco cleaning. We normally then put air bubble inside the eye, so this will help support the Descemet's membrane bit of stromal complex, so that it opposes against the back basically of the graft itself. So you get a bit of air tamponade while you carry on doing your final dissection. And this is your final dissection on the right hand side. So the sutures are basically now all in place nicely. You remove a bit of the air bubble. You make sure you give them antibiotics. Generally, we don't put a contact lens in these therapeutic cases because we want to get good penetration of our antibiotics into any of the residual basically stromal bed when we basically put it on the surface. And typically we soak the cornea before suturing it in an antibiotic as well, so you get some residual effect on any of tissue that basically might be on the recipient as well, while we're basically doing the suture itself. So at the end of the case, you basically remove the air, and of course you can see good attachment over here of the posterior lamella against basically the back of the recipient tissue. Okay, so in conclusion, DALK offers significant advantages over penetrating keratoplasty. You get better long-term graft survival, better endothelial cell loss, and you can lose lower grade tissue, i.e. lower tissue of lower endothelial cell count. However, it is technically a very challenging procedure, and rates around the world are actually quite low, as I showed you between the EBAA and the SCTS data as well. The main goal is to go as deep as possible, and that's one of the things that puts off a lot of people from basically doing the surgery, ideally, obviously, without perforation. Less residual stromal bed has been equated to basically better visual acuity. It's always better, of course, to start with optical cases, like some of the keratoconic cases I showed you with the big bubble. But these are the more easier cases to basically do post-infectious scars or basically corneal dystrophies. Therapeutic DALK, like I showed you with the post-op, the second case, is a lot more basically challenging to do, but you can get a lot of information if you have access to intraoperative OCT to basically do these cases. One of the big advantages in these kind of cases, especially if you do them in fungal infections, is that you don't need to give post-operative steroids to start with for quite some time, because you don't have to worry about the graft failing. Once the graft will take, you basically, your risk of basically rejection is low. The main thing you gotta basically watch for is any basically recurrence of the microbial infection in the graft tissue itself. But that's the key thing comparing this to doing a therapeutic penetrating keratoplasty. The barriers to adoption of DALK are related to technical aspects of the difficulty of surgery and experience, and this can be basically significantly shortened with intraoperative OCT. You can reduce complications that will improve your outcomes. So you get less double anterior chamber post-op. So day one, she was fine. She had no double anterior chamber on my lady, but I did tamponade inside of the surgery. You get less conversion of penetrating keratoplasty, and you get more information with respect to depth of your during basically the dissection. And I think this is the key information feedback that you get into surgeon, so you really know where you are, how deep you are, and what is going on with your dissection plane while you've been doing the dissection. Because when you're getting down to sub 50 microns or 50 to 80 microns depth, most other devices to measure corneal thickness do not work so well. Above 100, sure, they'll work well, but you know that you're going to be compromised with the visual acuity of itself. But when you're getting very much deeper inside the stroma and you're doing this by hand, this is where all these basic devices will fail. So I want to just acknowledge everybody at Leica who helped basically with getting these videos coming in on the weekend as well to help do video some of these cases. Some of these things can be basically preset on the machine, and some of the instruments I showed you are basically made by ASCO. I don't have any financial interest in them, and thank you all for your attention. If you have any questions, you can also basically go onto the poll or also basically send me an email. Thank you.
Thank you so much, Professor Jod, for the very interesting talk. So now is the live Q&A session. If you have any questions, please start to type it over, and we have our speaker here today to answer your questions. All right, so Professor Jod, the first question that we have, if the procedure encounters complications such as double bubble, micro and macro perforations visualization using the intraoperative OCT, how would you recommend to manage the surgery?
Okay, so they're all sort of different things. I mean, the management of the things will be slightly different. So double bubble, I presume you mean basically a type 1 and a type 2 bubble. So typically in that situation, what you will try to do is not open the second bubble. Okay, so you don't basically make a slash and open the second bubble until you've opened up the layer above the type 1 bubble. Okay, type 2 bubbles are extremely fragile. So your risk of basically perforation itself, if it's a round hole, like in that case, like I showed you, is not such at the end of the world to do the surgery. What you worry about is converting it into a rip. If you get a rip inside the descemes, that's a lot more difficult to basically handle because you've got to get the margin together. And typically with a type 2 bubble, you can basically get a rip. So the way we normally do this is that we will dissect away all the stroma if there's a mixed type 1, type 2 bubble. Right at the end, when we're basically going to put the recipient tissue onto the surface, we'll make a small nick away from the visual axis through the type 1 bubble to release basically the air from the type 2 bubble. And that's basically how we will handle it. Then you'll get a collapse of the type 2 bubble and you'll basically finish your surgery. But typically we don't open up the type 2 bubble if you get a mixed bubble situation. Okay. The second part of that is looking at micro and macro perforations. Yeah. So it depends on the size of the perforation and how you basically manage it. What you don't want to do is convert your perforation into a rip, okay, or big hole. So micro to macro. Micro perforations you can handle, like basically in that case, I put air inside the anterior chamber and I tamponaded the eye at quite high pressure during my suturing. And I do that trick basically all the time. And one thing you didn't see on the video is that I release any fluid that goes through the perforation hole through the edge of the DALK itself, so that you do get good apposition. And the OCT can nicely show you the apposition basically between the recipient and basically the donor basically tissue itself, so you get good apposition. So that's one trick that you can basically do. If it's a micro perforation, it depends on when it occurs during the surgery. If it occurs during the suturing, you need to tamponade it to stop getting a double anterior chamber the next day. Even if you do get a double anterior chamber the next day, you can wait a few days, go back, and then put another air injection basically inside the eye to try to help basically do the tamponade. What you're trying to do is get as much information during your surgery to help you that it will not basically convert your micro into a macro perforation.
Thank you so much, Professor Jod. So the next question, what is the different patient selection process for DALK versus PK surgery?
Yeah, okay, so that's a good question. So you can see by my numbers, basically we try to DALK everything. So I would say that everybody basically has primary stromal disease with a reasonably good endothelium, we will try to do DALK. But again, that's down to experience and it's down to having the comfort level to do these kind of cases. What I would say is that if you're used to doing penetrating keratoplasty and you want to learn how to do DALK, then you're in an ideal situation because you have nothing to lose to try to understand how to do the surgery itself. So the first kind of cases you would start with is typically a keratoconic case, and if that patient was getting penetrating keratoplasty, then of course you can try to basically do a DALK. So you can basically do no wrong. At worst case scenario, you're going to perforate and you're going to basically have to convert basically to do a PK, which is what you were going to do anyway in the first place. Okay. As you get more experience, of course, then you'll take on more basically difficult cases itself and try to reduce your perforation rate down. Recently, we had a paper in AJO last year that showed our series of cases of about over 500 or 600 cases looking at outcomes of perforation. So it's not that we don't perforate. Our perforation rate is about 18%, but our conversion rate is about 0.1%. Okay, so there's lots of tricks to learn how to reduce your conversion rate. Now, we have from experience, of course, you're going to basically be able to reduce that down. But the point is that you're trying to circumvent your learning curve a bit by using some technology to help you reduce that conversion rate.
Thank you so much, Professor Jod. A few more questions. The audience noticed that when you are doing the scan area is circular.
Yeah.
Is that more common than a rectangular scan, which they are actually more familiar with?
Yeah, so you have a choice basically. I prefer the circular scan because you can see all the way around 360 degree. The square scan is a raster pattern. So you're basically scanning across ways across the eye itself. I think raster is probably good for retinal surgery, but for corneal surgery, I think it's actually better to have the circular scan. I like the circular scan both for what I show for the EK and also for the DALK, because as a corneal surgeon, you really want to see what is going around you, read the whole thing. But you can use either scan that you want, and you can see that during the surgery, especially for that second case, we change the size a lot of that round circle. So the smaller the circle, the higher the resolution of the picture you're going to basically see itself, and you can see the shape of the cornea change as well. So when it was much smaller, it was actually almost flat. When it was much bigger, it was much more typically corneal shape that everyone would basically be familiar with. But I prefer the circular scan, but you can easily use the raster scan as well, basically when you're doing it itself.
Thank you, Professor Jod. So on the topic of scans, there's one more question here. Can you please explain why a radial scan is so important? What are the advantages?
A radial scan. So you mean a crosshair scan or So it's a circular scan. So the stills I showed you are, it's not a radial scan. It's a video showing 360 degrees, but I showed you as a single picture itself. So in that way, you're getting basically a shot all the way around, but it's actually taking a video of the whole way around. And you can change the resolution. The machine allows you to take up to almost 1,000 basically scans in that round circle. So you get very high resolution scans itself. So it's not actually a radial scan, it's a 360 degree scan. The other option, of course, that you have on standard mode is a crosshair. So the crosshair will show you in 2 planes. It's basically horizontal and vertical, and I showed some pictures from that as well. But you're going to be missing the information that is in between the crosshair, and that's why I like the circular scan itself.
Thank you so much. So one more question, the last question for today. With the improvement and advancement of technology, are there new and unique complications found or can be seen during the surgery? For example, risk of perforation.
Yeah, I think that probably the advantages is that you will maybe be able to predict or change the maneuver that you were going to basically do. I mean, that the therapeutic case I showed you is a particularly difficult case to basically do itself. And at least you can see where the instruments are basically going, where they are in the plane. You're keeping absolutely fine. I could have easily hit the lens, because I would, if I'd done this normally, obviously we'd done it blindly. Basically, I could have easily hit the lens with that instrument, even though I did put viscoelastic in there, and you're gently separating out the iris away from the endothelium and away from the hypopyon, away from the area from the back of the endothelium as well, with that instrument itself. So I don't think you're going to get new complications, but I think that you'll be able to hopefully recognize some things earlier and then avoid basically getting complications that would normally basically occur, or all of us have basically been through. 30% of I mean, if you look at perforation, it's very simple when they normally occur. 30% almost occur during the initial trephination. 30% of them occur, so the initial dissection, 30% of them occur during trying to get a bubble if you're going to go for a big bubble surgery, and 30% of them occur basically during the suturing phase. So at all those points, you can easily perforate, get a microperforation, then you're going to have to basically try to solve that at the time of surgery and try to help you with the dissection during that time period. So you need to then be aware on how you're basically going to solve that. So I think that having as much information when you're doing the dissection, especially for this surgery, because I think it is very difficult, though, and I think that technically it's probably the most difficult surgery that we do. But of course, if you're able to achieve the surgery, your outcomes are fantastic, because of course you get much better survival in the long term. So patients will benefit hugely if you can do the surgery. But the problem is that technically it is a much more complicated procedure compared to most other corneal surgery, or even most surgery that we do on the eye.
Thank you so much, Professor Jod. Okay, so that actually wraps up our session today. The recording will be shared with everyone, as well as the link to session 1 in case you missed it. All right, so before we wrap up today, there are product experts from Leica Microsystems that are able to give you a live demonstration to support you in your clinical work. So if you are interested, just let us know in the polls, which we have started, and we will get back to you. All right, so that brings us to the end of today's session. Thank you so much to Professor Jod for the very educational session today, and thank you so much for your time in joining us. Take care, stay safe, and thank you so much.
Thank
Good
you.
night and goodbye.